Thank you, Dr. Cabral. Such rich insights, a very successful session one. Thank you, Professor Lee. More power with the amazing Esther Project. Leon, more power with your groundbreaking projects at the Consumer Health Forum. And Itita, thanks for reminding us of the critical role that patient organizations play in humanizing the healthcare and upholding patient care and making sure patients have, as Leon mentioned, choice, control, and being change agents. Before we proceed, we will now take a 10-minute break. There will be a timer on your screen to remind you of the time. Meanwhile, during the break, try to visit the photo booth, have your photos taken and post them on social media using the hashtag APPC 2021. You can also check out the videos playing in the auditorium to see what other patient advocates are doing in the region. Thank you once again and see you shortly.
The International Alliance of Patients Organization has helped shape the global healthcare agenda for the past 21 years by putting the patient at the center of healthcare systems.
With an ECOSOC consultative status, this gives us a unique opportunity to raise issues of global health importance at the member states and with other leading non-state actors at the World Health Assembly and the UN General Assembly. We distill health and policy issues that are agreed at the World Health Assembly and the UN General Assembly so that members can understand in real terms what their government should be doing.
We take information from the WHO, reputable journals, as well as patient experience and distill it down into practical, digestible and actionable information so that the patient can confidently engage in dialogue with their physician.
AYAPO is the global voice for patient-centered healthcare, and the value it brings is to provide members with a range of toolkits and policy briefing papers to help them advocate at the grassroots level.
Make the patient's role stronger by ensuring they're seen as equal partners. AYAPO is responsible for the first globally accepted definition of patient-centered healthcare, and it's one that was developed and agreed by patients' organizations from around the world.
Since 2005, our biannual Global Patients Congresses help our members build their skills and knowledge, as well as extend networks of patient advocates from around the world.
Every year we have a Patient Solidarity Day and a World Patient Safety Day that brings us all together to address common challenges as a single patient body.
We currently have 271 patient groups across 71 countries and work in 52 disease areas. And our work is greatly enhanced by our cross-sector alliances and partnerships.
Our cross-sector alliances involve working collaboratively with like-minded medical and health professionals, policymakers, academics, researchers, and industry representatives towards patient-centered healthcare and universal health coverage.
Our healthcare industry partners commit to supporting us with various levels of unrestricted financial support, which in turn support accountable, transparent, and efficient collaborations.
The pandemic in 2020 has clearly highlighted the need to make major changes and future-proof our healthcare systems.
Never before has there been a greater need for an alliance such as AYAPO. A diverse, inclusive, and multicultural organization is truly most effective on a global scale.
We can all recover together, and we can address our challenges effectively through national unity and global solidarity.
So as an AYAPO member, you really do have the opportunity to influence and make an impact towards better healthcare for all.
Greetings from the Thalassemia International Federation. Our federation is an umbrella organization for patient support groups in 64 countries in which there is a prevalence of inherited hemoglobin disorders. These are the commonest hereditary conditions causing severe clinical pathology, and they require complex treatment and monitoring. Our aim is to promote services for optimum patient care, aiming for the best patient outcomes in terms of long survival, minimum complications, and a good quality of life. Hemoglobin disorders in the past were lethal conditions of childhood. However, optimum care can guarantee all of the objectives. The reality, however, is that the majority of patients around the world receive less than optimum care and suffer a poor quality of life and premature death in their teens and early childhood. These conditions are primarily Asian, since the highest prevalence is from the Middle East across to the Pacific coast. In 34 Asian countries, and we have members in 30 of these. Like many congenital lifelong disorders, they take second place in the attention of health authorities, and advocacy is needed, even for the provision of basics, such as adequate and safe blood and a constant supply of essential medications. Inequalities in the provision of services are prominent, not only between countries, between rich and poor, but also within countries, especially between minority groups. In this respect, the plight of migrants, and especially refugees across Asia, has to be emphasized. They are often marginalized or depend on charity for the basic human rights to be satisfied. Our organization is dedicated to address these inequalities, which cannot forever be accepted as part of life. It cannot be expected to have one patient cured by genetic therapies while another 10,000 stand by and watch, unable to find support for unaffordable treatments. Health systems have to be challenged, and only a strong patient voice can do this. However, patient education and real knowledge of their condition and its treatment are required. Patient involvement in policy decisions and in health systems development will ensure that authorities will not leave such groups as these groups out. We live in an era where technology can support teaching and educating patients, educating the community and healthcare professionals. Authorities must be sensitized and realize that allowing complications to arise.
And we're back. Welcome everyone to session 2, Strengthening Health Systems Through Patient Co-Creation in Reorientation of Healthcare Using Digital Healthcare. Moderating the segment is Shanti Shamdasani, CEO and President of the Asia Pacific Government Affairs and Market Access South ASEAN International Advocacy and Consultancy. Speakers for today are Dr. Shekhar Potkar, Regional Chief Medical Officer of Emerging Markets and Head of the Global NCD Excellence at Viatris. We also have Netnapis Suchonwanich, Management and Technological Advisor to the Office of the National Health Commission. Last but not the least, we also have James O'Brien, Vice President for the International Prader-Willi Syndrome Organization. You can find their full biographies on the Congress website. Please feel free to submit your questions in the Q&A tab in the auditorium. I now turn over the virtual floor to Shanti Shamdasani. Over to you, Shanti.
Thank you for that, Kara. Good afternoon, good morning, everyone. It's an honor to moderate this event with such an interesting topic. I think when you mix technology and compassion, these are the two keywords which at times doesn't blend in together. But what we see currently happening is that, especially after COVID, is that technology has actually taken a major role in addressing some of the patients' challenges in terms of meeting with the doctors, meeting with the practitioners, And then you see how technology actually is beginning to replace that patient-doctor relationship. But the question is, where does compassion lie in this technology-driven world? And when I talk to doctors, they just smile and they say, well, if in terms of really patient care in the past, there was a heavy emphasis on compassion, but with technology more and more taking place, that compassion side is being downplayed. We want to understand today from our speakers. We have three very good, distinguished panels of speakers who would walk us through really how can patient help to co-create and integrate technology along with the medical deliverance, and what are the role of patients and the role of healthcare practitioners moving forward to address this issue. I think these are very key aspects that we need to address, and especially after what we have heard earlier in terms of how compassion play a bigger role in patient recovery and the future, how this continue to play in the future. So without further ado, maybe I would like to invite our first speaker, Dr. Shekhar Potkar. He's the Regional Chief Medical Officer, Emerging Market, Head of Global NCD Excellence at Viatris. And he'll be sharing with us how Viatris uses digital channel to improve patient outcomes and care. And he'll also share with us some case studies from Asia Pacific, which is using digital solutions to impact health literacy, health professional education, and patient outcome. So I'll hand over to Dr. Shekhar Potkar. The time is here, Doctor.
Thank you very much, Shanti. And I'm excited to join this illustrious panel of distinguished experts. At the outset, let me thank the organizers from Asia Pacific Patient Congress for the opportunity given to me to talk about this very important topic. I think, as Shanti mentioned, there are two critical variables here. One is digital, and second is the active role that patient community across the world is playing. And this is against the backdrop of the pandemic. So what I'm proposing to cover there are three topics which I would quickly want to touch on. One is really how this pandemic has disrupted the patient journey. I will take the example of non-communicable disease patient. Secondly, I would want to offer a framework that we have been using within our organization to address the digital disruption, and how can we leverage and leapfrog the digital disruption for the benefit of the patient and physician care. And finally, I will provide you with some case studies in Asia Pacific that we have been able to start implementing, taking the advantage of digital and leveraging patient voice. So without further ado, let me jump into my first slide. This is a slide which will, can we move on to the next one? This is a slide which depicts the patient journey. I think all of us are very familiar with the 5-step patient journey, starting with awareness, screening, diagnosis, treatment, and adherence. And we are also very familiar with there is extensive literature around the pandemic impact on the patient journey, especially the non-communicable disease patient journey, which is what I'm referring to in this conversation. So we have seen pandemic impacting health awareness. There are patients across are becoming increasingly health aware. There are spillover effects of the pandemic on screening and diagnosis. We have seen care gaps in the treatment, and adherence has been impacted negatively across different regions. Digital has been a key pivotal factor in allowing us to leapfrog the change or the disruption that we would not have been able to imagine for the decades earlier, which has happened in just 1 year. And two main streams of this disruption. One is information of how we are able to drive the information to our communities. And secondly, innovation. Innovation not only in interventions, whether it is vaccines or treatments, but innovation in the approaches to deliver care, whether it is primary care model, how do we assess risks, how do we ensure adherence to the chronic disease treatments. These are all innovations that we have seen come live in the last 1 year of the pandemic. So with this context of how pandemic has impacted the patient journey and how digital has been a critical influencer or critical disruptor in ensuring that we transform the delivery in this context, let me jump into the next slide, which highlights the framework that we have developed within our organization. We are looking at how do we reimagine the new normal. There are 4 pillars that we have taken into account. One is how do we ready ourselves, organizational preparedness. Second is looking at the new patient journey, how post-pandemic patient journey would look like. Looking at new physician journey, HCP, healthcare professional journey, new customer journey. And finally, do we have enabling policies in the new normal? So that's the 4th pillar of reimagining the new normal and how we can leapfrog using digital as a disruptor. Let me just quickly go over each of these 4 themes. In terms of organizational preparedness, it ranges on from a number of parameters, whether how are we interacting with healthcare community at large, whether virtual operating model, whether we are able to leverage our networks in the form of partnerships. So this entire number of areas that we are really focusing around organizational preparedness. Under new patient journey, as we discussed earlier, from five-step patient journey from awareness to adherence, we're looking at a range of solutions which go beyond the pill, not just the interventions, but can we really support the patients and the healthcare community at large in providing solutions, whether it is apps, websites, looking at care models, looking at virtual telemedicine. These are all the areas which really kind of the confluence of these forms under new patient journey. The new customer journey or the new healthcare professional journey, here we are talking about how physicians approach different partners for updated medical education. How do they conduct research, real world data? How do they really get involved in the form of conducting the database or the real world research using artificial intelligence, social listening, and various new technologies which are emerging? So these are the themes which are covered under new customer journey. And finally, the policies part. How do we really leapfrog policies which will enable the new normal? And here, the main conversation that one of the critical themes is around equities. Are we able to balance the social determinants, which is a very important conversation in our part of the world, to see are we able to work with the policymakers and the governments to address some of these policy gaps that we see. So this is a framework which we have found very useful. Let me jump into the next and the last slide that I have, which will essentially walk you through some of the case studies that we have started piloting post-pandemic. We refer to this platform as a connected health because this is a platform that allows us to connect various stakeholders in the healthcare ecosystem, from patients, governments, physicians, to all the other players who are involved in delivering care to the patients. So here on this slide, you will see the patient journey and the physician HCP journey mapped, some of the critical pillars from awareness to adherence and the education, as well as evidence generation, which are the critical areas which from the point of view of healthcare professional. I'll just call out 3 examples on this slide. If you look at awareness, this is an example from Malaysia where we have partnered with various stakeholders in country to create My Health, My Life as a credible patient information portal, which is now reaching 1 million users in just a time span of 1 year. And this is creating and making available point of care, credible medical information for the use of patients. Second example, again from Malaysia, is on clinical practice tools, which is essentially addressing the diagnosis and the treatment areas around patient journey. Here you can see a program that we have championed called iManage, which brings in 7 professional associations from primary care, retail, looking at specialty associations in Malaysia, 7 professional organizations coming together and really linking pharmacists with the general practitioner, with a specialist, the 3 critical pillars in caregiving, diagnosis and treatment, linking them to provide education and creating a referral mechanism, as well as making sure that patients are provided the necessary information by pharmacists as well as the general practitioner, and ability to know when to refer. So these are the kind of clinical practice tools iManage program, which is very well underway in its 2nd year now. And the third one here is an example which is across emerging economies. We have partnered with American College of Cardiology and a host of stakeholders, NCD Alliance, World Heart Federation, to create NCD Academy. And NCD Academy is a program which is rolled out world over, but very specifically in our part of the world, in emerging economies in Asia, where we, again, it is directed at primary care providers as well as general patients at large, provides high quality medical education around non-communicable diseases, mental health, hypertension, dyslipidemias, cancer, diabetes. These are the types of topics where we will be able to have a very high quality education, as well as some of the assessments that we have built in. And these are some of the examples that we have really launched using the Connected Health platform. There is an example of artificial intelligence and social listening in Thailand that we have also looked at from an evidence generation point of view. How do we create the new evidence where we see significant data gaps or the evidence gaps in our part of the world? So I will pause here. The purpose of this conversation was really to introduce the disruption which is caused by the pandemic across the patient journey, introducing our framework, and looking at some of the case studies using the Connected Health platform. I just want to leave you with one thought. Digital as a disruptor has been a significant influence during the pandemic. However, we should look at this as a crisis of opportunity, an opportunity which allows us to leapfrog. We don't have to go through the entire years of cycles of progress to see digital disruption to happen. It has happened overnight during the pandemic, and we have a huge opportunity to leverage this digital disruption to improve the patient care from physician's point of view as well as from the end users, the patient's point of view. Thank you very much for the opportunity. Let me hand it over back to Shanti.
Thank you very much for that, Dr. Shekhar Potkar. I think he cited a few very good case studies and examples. I would just quickly touch one on Malaysia, where he did mention on iManage and several professional institutes coming together to ensure that patients have access to the right kind of medicines. I think this is something which, again, the digital revolution or transformation has taken place overnight during COVID time, and this is one evidence of it. I think thank you for that, Dr. Potkar. I'm going to move to our next speaker now. Her name is Netnapis Suchonwanich. I hope I pronounced that correctly. She's the Management and Technological Advisor to the Office of the National Health Commission and the National Health Commission of the Office of the Thailand, the National Health of Thailand. She'll be covering in this session on how Thailand have achieved the national health coverage and what is the experience during the COVID-19, especially 2020, which was a very heavy year for all of us. And she'll also be talking on people-centered health information to precision machine and health literacy. So now I hand over to Net. The time is yours, Net.
Good morning, ladies and gentlemen. Pleasure to be here. It's an honor for me to have this good opportunity to share our experiences from Thailand, that how Thailand achieved their universal health coverage, and how can we use the information system to develop our precision medicine and health literacy. Go to the first slide, please. Yeah. Back to the year 2002, which is the first year that Thailand have implemented the universal healthcare coverage in Thailand. Although at that time we are still in the level of a low-income country, this is a very challenge for us to achieve the USC. For the strategy of the information at that time, we try to achieve the first ultimate goal of the USC is the population coverage. So we create the linkage with the Ministry of Interior in order to make every life count. So we initiate our population database at the national level, at the National Health Security Office. And we also implement what we call enterprise application integration. We have to exchange the data between the Ministry of Interior. We submit the health insurance data or eligibility data to the Ministry of Interior in order to embed it into the national ID database. And also the Ministry of Interior return the birth and death data back to the NHSO. So we know everyone that have a newcomer of our beneficiary, and we know who have a dead, and we can delete from our database every day. So this is a very good option for us to establish the most updated data at the central level. But again, the problem is still because the juicy schemes in Thailand have to cover just only an insured person that not are covered by any health insurance, such as the Social Security that cover the formal sector, or the civil servant that covered by the government. So we have tried to find the uninsured. So the problem is that at that time, we didn't have any linkage with other health insurance scheme regularly. So we have to set up the steering committee in order to make a commitment that every health insurance have to information sharing to National Health Security Office. So that's why we can cleansing our eligibility data very well. So within the 3 years, we can reduce the error of the enrollment data from 12% to 0.0. So this is the first of the achievement to make every life count. But again, like now, we still have some of the vulnerable people, and the people with no ID is still left. So our last step now is trying to implement the survey to this group, try to find and try to identify and generate the ID for them in order to make every life count. So this is our the first achievement. Next slide, please. And in order to ensure the access to health service, we also decide what we call health service network. The health service network is to decide for each beneficiary. They have to choose their network. Once they have to go to visit the doctor for outpatient service or prevention promotion service where they want to go, and they have to choose the nearest facility or provider nearest to their home. And for the referral system, they have to choose the inpatient. But this network have to be decided rationally, not to choose any hospital that they like. We still have a strategy that we use the nearest provider that they like. So this can ensure the access to health service when they need it. Next slide, please. And in order to ensure our reimbursement, the National Health Security Office have reimbursed our fund through have reimbursed. Excuse me. We also reimburse our service by training the hospital to send the data through our application. So all the hospital have to submit their outpatient service and the inpatient service through the application to the National Health Security Office. So a large amount of the data comes to the NHSO, 200 million record per year for outpatient and around 8 million record for inpatient. In the year 2008, we found the problems of manage to some specific disease. So we decided disease management information system in the year 2008. So we also developed what we call individual medical record for some specific disease. So all of the individual medical record has a gather at the centralized database. Next slide, please. But again, what I explained is not good for the design, but the result is that the expenditure of the health increased very quickly after we implement for USC. You can see that the increasing rate of the UC, especially for UHC, for UC scheme, increased very quickly, and the government tried to control our budget because they argue that how can you make it more sustainable if you are increased too quickly? We cannot afford. So we have to explore inside, and we found that the proportion of the increasing come from the medicine. So the first strategy for the government is try to control for the medicine and make it more quality for the patient to access. Next slide, please. In the past, for the dimension of the achievement of UHC, we also look at only three coverage. First is the population coverage. The second is the service coverage. And finally is the financial risk protection. But now people are professional and also for the industrial, they need more. So they ask for the quality of care. So we have to add more dimension to make more satisfaction for every partner. Next slide, please. But again, I think it's the same like every country. It's very easy in Thailand. Once you want to access the care, you just only use the smart card in order to access the your provider. You can go to have a outpatient visit at the primary care, and once you have to have any admission, we have a referral system to the acute care or intermediate care. But the problem is still because all of the data here is a long journey and cannot corroborate together. So right now we try to enhance our record into what we call patient-centric design. It means the whole life story. Use our national ID in order to link the data from birth to death. So this is what we decide. So we can link the data for one person, although they have to visit anywhere. And we try to create what we call one individual medical record for one beneficiary. Next slide, please.
Net, you have, actually time is almost up. So,
yeah. Okay, thank you. I will try to conclude. Moving to the precision for better outcome, Thailand have implemented a lot of the precision medicine, oncology, rare disease, orphan drug, seizure drug and antiretroviral in order to make it more precision by use our patient-centric record in order to make it more specific. Next slide, please. Yeah, we designed the precision medicine in the UC scheme and along with the Social Security scheme by using the information system linked with the private laboratory in order to make it confirmation for the one patient that fit for each medicine. And then all the data have a transfer automatically to the government pharmaceutical organization in order to deliver the medicine directly back to the hospital. So I think that this picture is make a conclusion for the precision medicine if you want to try to implement like this. But next slide. It cannot be, next slide please. It cannot be used for some medicine that need more management, such like that they know any interest from the drug company to import or manufacture. It cannot be used for some specialists that not available in the remote area. So for the antidote and antiserum, we apply the pharmaceutical management cycle from the WHO. We try to decide to cover the selection, procurement for the stock, distribution, utilization, and management support. So I think that the design is a comprehensive design for some medicine that need more management. Next slide, please. And now we are move forward to use our big data technology to implement what we call the individual medical record to link with precision medicine and health literacy. Next slide, please. We use a new design of the big data technology to establish a data lake at the National Health Security Office. And now this data are provided for the researcher and also for any platform to connect. And then we can provide to fit with their service or their literacy. Next slide, please. This is some of the example that we use our mobile phone to make that precision access to their health record or the precision of their health literacy by protect their privacy regarding to our privacy law. Next slide, please. This is what we have designed. Other organizations just only provide their product, but the National Health Security Office will correct the key that we have and submit to other provider, and then they will return their product to us, such as the Thai Health Foundation just only send the key of gender, of age, and the disease. They can access directly to the precision of the health literacy, like the NCD, right? And the last two slides are some of the example. Next slide. Yeah, this is the health service from the NCD record. Next slide, please. And this is what the health literacy they provide for each one. And some in the future, some hospital can provide the appointment. We can also access what the appointment that you have to see the doctor. Okay. I think this is all that we have done now. Thank you for the attention.
Thank you for that, Kunnet. I think a very good example from Thailand in terms of how they've used big data into forming what we call a precision medicine for patient. Absolutely brilliant. I think one of the best examples we could have here. I'd like to move now to our next speaker, Mr. James O'Brien. He's the Vice President, International Prader-Willi Syndrome Organization. He'll share with us a complex syndrome like Prader-Willi syndrome needs a multi-system and multi-stage responses and how that can be achieved. He'll also talk about the use of Project ECO, extension of community healthcare outcomes, method to democratize and simplify complex knowledge to benefit rare patients. and also how patients' organization can take the lead to drive evidence-based change in this area. Without further ado, Mr. James O'Brien, please, the time is yours.
Thank you, Shanti, for your introduction. Next slide, please. It is my pleasure to be with you all today and to give you a brief overview of how the International Prader-Willi Syndrome Organisation, which is a patient-led organisation, has utilised Project ECHO to deliver supports and to share knowledge in the field of PWS. But firstly, just very briefly, a little about PWS and about our organisation. Prader-Willi syndrome is a complex, rare, neurodevelopmental condition, and in the very simplest of terms, it's characterised by extreme floppiness and failure to thrive at birth. Then this switches to an excessive drive to overeat at around the age of 4. The symptoms can be managed, but information is key for both the professionals and the families. Without an early diagnosis and without that knowledge, an infant may not survive its early years. Then overeating starts. Then dangerous obesity and associated health risk can easily develop. Next slide. The International Prader-Willi Syndrome Organisation was established in 1991 to bring together the families, healthcare professionals, caregivers, researchers from around the world. Delivering information to healthcare professionals and parents has been centre to our mission right from the start. Next slide. IPSWO operates globally, working with 41 established PWS associations, shown here in pink. We support them in their activities and their daily advocacy. We also have contacts in a further 100 countries, shown here in orange, where we provide direct support to families and professionals in those countries where rare disease infrastructure and knowledge might not be present. We are also currently working on a webinar series to try and engage with contacts through Africa. Next slide. I became aware of the ECHO model in 2019 when I took a year out to travel and learn about how technology might be harnessed to improve health outcomes. Whilst in the US, I met with the team at the University of New Mexico. Professor Sanjeev Arora was facing a dilemma. In 2004, hepatitis C was running rife across New Mexico with some 28,000 cases. A cure was available, yet Sanjeev was only able to treat around 1,400 patients, around 5%. His books were full and people were dying of hepatitis C due to a lack of access to treatment. So Sanjeev set about establishing Project ECHO to democratize the knowledge and to train doctors across the state. Now over 70% of participants are receiving treatment. ECHO, which stands for Extension of Community Healthcare Outcomes, has demonstrated its suitability for adaptation to any complex or rare disease. The methodology revolves around a core concept of all teach, all learn. Bringing people in spread out geographic locations together in an online community of practice using Zoom technology. There are 4 guiding principles: amplification, through the use of technology, the sharing of best practice, the treatments, case-based learning, that is the discussion of de-identified cases within the online community, and monitoring outcomes for continuous improvement. Next slide. For us at IPSWO, the challenge has been how to enable expert learning in a rare disease, then how to transfer that complex knowledge from the minds of usually city-centric experts to the minds where it is needed most, the frontline GPs and doctors in the community where the patient lives. A graphic example of this, when I was privileged to do a 12-hospital lecture tour in India, a family came some eight hours by train to listen to us, a family that could ill afford to travel. They couldn't afford to stay the night, so they needed to travel back again the same day. And it just demonstrated so clearly and graphically that we need to take the knowledge out to where those people live, not to expect them to travel such long distances. With our audience, with our IPSWO audience spread across the world, we have always been an early adapter of technology. And we are now delighted to be using Zoom for health interventions. We have developed 4 ECHO programs: a leadership ECHO, which seeks to strengthen the skills and knowledge of leaders in Prader-Willi syndrome, that is, the associations around the world. A Latin American ECHO, conducted in Spanish to support the needs of families and professionals across South America. A healthcare ECHO, which shares health knowledge about the treatment of PWS among health and allied health professionals. And finally, a caregiver ECHO, aimed at training professional providers of supports in daily living. The PWS Project ECHO has so far reached 74 countries, including in this region, Australia, New Zealand, Indonesia, Malaysia, Singapore, Thailand, India, Vietnam, Japan, and Nepal. Next slide, please. PWS is complex. It affects multiple systems in the body and presents over multiple stages throughout life. It affects both physical and mental health and requires a multidisciplinary approach to treatment. The IPSWO ECHO model is open to a wide range. The IPSWO Health ECHO model is open to a wide range of health and allied health professionals who work with PWS. The topics that are discussed in the sessions, which are hour-and-a-half session once a month, the topic is determined by the needs of the participants, by the doctors, and range across subjects such as behaviour, mental health, sleep, respiratory disorders, diet and nutrition, hyperphagia, and endocrine. Feedback has been positive, including this recent quote from an engaged participant who said, "PWS continues to be an emerging jigsaw of discovery. Unlike other jigsaws, I advise against starting at the corners or the edges, as they are always expanding. As a provider, I am as keen as ever to keep learning and sharing with colleagues, families, and professionals. These sessions support that objective." Next slide. Launched with the support of Pfizer and Friends of IPSWO, our Leadership ECHO was the original first program and has been dedicated to developing strong leadership among people running PWS associations. Sessions follow a format of an educational presentation or didactic made by an expert, followed by breakout networking sessions, then regrouping for case presentations, followed by discussion to try and find solutions to the cases that are presented. The didactics are then recorded and saved for an ever-expanding online library to enable people to visit the knowledge at a later date. Participants benefit from sharing and learning from each other, coming back to that all teach, all learn aim, meeting their peers and discussing issues in depth. Next slide. Information concerning attendance, session content, survey data is all collected and analysed. Using this information, plus more in-depth interviews, IPSWO has been working with a student from the University of Cambridge to evaluate the leadership echo. According to the survey data, participants now understand more about the syndrome, more about how people with PWS feel and think. They have a better knowledge of the current best practice in both health and social care. They are more confident in talking about PWS with medical professionals, families, friends, and the wider community, and are more confident to act as a resource for people to come to for support. And finally, well, not finally, but and express that they will be able to strengthen their PWS associations and networks for families in their countries. Several participants have also established or expressed an interest in establishing ECHOs in their countries. So the findings from the evaluation show that there is a need for the ECHO program. It can be applied simultaneously to more than one country, and that ECHO can be established for rare diseases to help reduce global disparities. Next slide, please. In conclusion, our evaluation indicates that the program has been well received, well attended, and valued. It is a model which is offers useful learning for other patient organisations. ECHO is particularly relevant to share knowledge about rare disease where there is scarcity of resources. Of course, there are challenges and areas for improvement. It is difficult working in different time zones, and there are cultural differences to acknowledge. Local differences in the provision of healthcare are challenging, as well as issues of access to technology. However, Project ECHO is now a key enabler of IPSWO's strategy to grow and strengthen the world PWS community. Next slide, please. ECHO, as you can hear, is something that we are really passionate about at IPSWO. And if you'd like any more information, please feel free to follow up. Thanks for your time.
Thank you for that, Mr. O'Brien. I think that is another very good example on how technology is being used to support patients in different parts of the world. I think the ECHO model is certainly something, especially during COVID time, has been replicated in various disease areas. I know my friend who suffered from autoimmune disease is actually attending events based on this model. Thank you for sharing that again, Mr. James O'Brien. I'd like to get into a short Q&A session. We have around 10 minutes left for our Q&A. So maybe the first question which I have here is, and of course, feel free for all the speakers to add in, if you feel that there's a requirement to do that. But the first speaker I see here is for Dr. Shekhar Potkar, and the question is, do we need a framework of laws, or do we use practice guidelines and protocols for reorientation of healthcare to make it enabling for co-creation? Is it carrot or stick? And this is, again, feel free for other speakers to jump in.
Yeah, thank you, Shanti. I think this is a very, very potent, powerful question, and I'm sure I would be very keen to listen to the perspectives from my other panelists as well, Net and James. But let me start off. I think what we have realized post-pandemic is the disruption which is caused by digital and the active roles that patient community across the world are playing because of information and innovation. These are the twin forces which are leading to this entire disruption. So this is not an option anymore. This is the reality. This is the new norm. And therefore, we will all need to really play our part very actively. If we are a member of a pharmaceutical industry, if you are a stakeholder from a physician community, if you are a patient, or if you are a government, I think all of us will have to play our part very actively. Those organizations which have been agile, quick to adapt and adopt, I think those are probably going to lead the way in driving this new normal. So my personal opinion is I think it will have to be collective effort driven by all the stakeholders in the community. More than a carrot and a stick approach, I think it has to be a conscious realization that this is the once in a lifetime disruption, and all of us will have to play a very keen role to enable the new normal. So that's where my point of view would be.
Thank you for that, Dr. Shekhar. The second question I have, is there anyone who wants to jump into the first question to answer? Okay, great. The second question I have here is, do you think patients and families know more about the weaknesses of their healthcare systems than their healthcare providers? The question again, let me repeat. Do you think patients and families know more about the weaknesses of the healthcare systems than their health providers? And this is, James, please.
I would say that with a complex syndrome like Prader-Willi syndrome, invariably the families know more than the providers. It's through no fault of the provider, really. You've got a lot of knowledge to learn, and when one syndrome is so complex, it just gives you an overload. So yes, in some instances, I'd say that's true.
Okay. Dr. Shekhar, do you want to add to this?
Shanti, I think I work in the area of non-communicable diseases. That has been an area of passion for me. And across these disease spectrum, I think what I have very consciously seen is, though we of course have, each stakeholder has a role to play, but patients and especially their caregivers, their extended family members have a very significant role, and they understand the lacunae in the system much more than even each stakeholder might have a perspective from their point of view. A pharmaceutical industry might see a pie of the whole, but only the patient and their caregivers are able to really see where the rubber meets the road. So I would really believe, I would agree with James, that it is the patient's families who would know much more about the gaps in the system.
I have a question from Snap.
Yep. Since in Thailand, we agree with this opinion because, in the family, they understand more about the patient more than provider because they stay with the patient all the time. So that's why the guideline for our HTA implementation, we need the partner from the provider and not from the provider. We also from the community, from the family, in order to make concrete of the research question and also make a consensus of our result because they know more. And in another aspect that the provider don't know. So I agree with this. We have to collaborate them in our process.
Right. Thank you for that, Ms. Net. I think just one question for you, Ms. Net. And the question is, I think the evaluation or the evolution of the Thai Patient Association and how Thailand has used big data into really getting into the precision medicines has been exemplary. I just have one question. Do you also work closely with the Ministry of Digital Transformation on this one, or you are kind of like separate? Because after COVID, we see a lot of technology interference. And do you experience any technology upgradation on the current effort that you're currently doing?
Fortunately, that I work very closely with the Ministry of Public Health and also work with the health technology assessment. And I'm also graduate from IT as well. I'm not only pharmacist, so I try to corroborate the information from the provider and with the government side and with the IT side. So for the big data technology, I think that is the time for every country have to move, but it's very hard because the fundamental is very weak. So that's why I try to mention to establish the fundamental system in order to make it to move forward. So although at the COVID, they have a drive a new technology to us, especially for the mobile application. A lot of the community isolation, home isolation, they also develop a lot of the information to share. And we think that we can overcome the COVID, not just only from the government side, from the community side. So I appreciate to move together with the community.
Good. So I think this concludes our session today. I think I must say that it has been a very good highlight for all of us. In terms of how technology is being used to reach out to patients and provide more quality. I think that's the whole gist of the message here. I'd like to thank our speakers for your time and your contribution. And I'll return this to our MC, Kara, and the organizer. Thank you again.